Associer l'hormonothérapie aux nouvelles thérapies ciblées, c'est l'évolution sur laquelle nous allons à présent nous arrêter, avec une incursion sur la piste des conjugués anticorps-médicaments qui pourrait constituer la dernière révolution en matière de thérapie combinée. Monsieur le Président.
It's a really great pleasure for me to introduce François Duhoux, who is a professor of medicine at Université Catholique de Louvain, where he teaches medical management of breast cancer and hereditary cancer predisposition syndromes. He's both a medical oncologist but also a clinical geneticist. He has actually done his PhD in genetics linked also to hematological diseases, and now he specializes in the care of patients with breast cancer and management of hereditary breast and ovarian cancer. He's very active in research on next-generation sequencing and stratification of the breast and ovarian cancer. He is head of the research section within the breast cancer clinic. He obtained his medical education from our university in 2004. He underwent a number of training positions in internal medicine and medical oncology, both in Belgium and in France, most notably Institut Curie in Paris. He also has an oncogenetics degree from Universitaires Paris 7. And he is also active in the field of drug development, and is currently the president of the Belgian Society of Senology and a member of ASCO, ESMO, BSMO, and the American Association for Cancer Research. Thank you very much. Looking forward to your presentation.
Monsieur le Président, Monsieur le Secrétaire perpétuel, Mesdames et Messieurs, it's a great honor for me to be standing here in front of you, and I'm really very glad to follow in the footsteps of giants of oncology that you had the privilege to hear this morning. As an introduction, I have conflicts of interest with all pharmaceutical companies whose drugs I will present today, and I will today discuss mainly luminal breast cancer. So Professor Picard already introduced the different subtypes of breast cancer, so we will focus on subtypes of breast cancer that express estrogen receptors. These subtypes of breast cancer are the most frequent ones, so almost 3/4 of all breast cancer cases have this expression of estrogen receptor. And why would we like to improve our treatments and not use classical endocrine therapy for these patients? Well, mainly because these estrogen receptor positive breast cancers have a tendency to relapse a lot late in the course of the follow-up. You see here patients with more than 4 positive lymph nodes, estrogen receptor positive breast cancers. Half of them will relapse after 20 years, and these relapses are, in most cases, unfortunately, still deadly today. So it's very important to improve endocrine therapy for patients with early disease. But it's also important to improve treatments of patients with metastatic breast cancer. This is a study that was published 4 years ago now concerning the outcomes of patients with metastatic breast cancer treated at French Centre de lutte contre le cancer. So you saw presentations of 2 distinguished members of these centers. These centers treat their patients extremely well, but nonetheless, unfortunately, median overall survival of metastatic breast cancer remains poor. It's approximately 3 years median overall survival at the moment, and the only subtype of metastatic breast cancer that has shown an improvement in survival over time is HER2 positive disease. You can see that patients who were diagnosed before 2008 here on the lower curve have a poorer prognosis than patients who were diagnosed after 2013, and this of course is due to the advancement of these new therapies that Professor Picard so elegantly described. Unfortunately, in estrogen receptor positive disease, HER2 negative subtype, there was no improvement in median overall survival, at least on the curves that were generated for patients who were treated after 2013. But we hope, of course, with the advancements that I will show you now, that this curve here will also start to improve. And just a quick note on the worst subtype of breast cancer that we will not discuss today, triple-negative breast cancer. Median overall survival from diagnosis is just a little bit over 1 year, so that's really a very, very bad prognosis. So why, in summary, do we need better therapies for these estrogen receptor positive HER2 negative breast cancers? It's because it's the most frequent subtype. It's the subtype with the highest rate of late relapse, and there was very little improvement for these patients who were classically treated with endocrine therapy and chemotherapy. Endocrine therapy, as you know, was developed well before my time. It was developed in the 19th century when surgeons discovered that by removing the ovaries, they could make most breast cancer tumors shrink. We now have more elegant ways of dealing with endocrine receptors than just removing the ovaries, and we know that we can use LHRH agonists to suppress the ovaries without removing them. We can use aromatase inhibitors, and we can use anti-estrogens. So these are the tools that we had in our toolbox. How could we improve the efficacy of our treatments by using these tools? Well, one of the first ways to do this was to increase the duration of the treatment. Classically, in the adjuvant setting, endocrine therapy would be given for 5 years. We now have several trials, I will not go through all of them, showing that when you increase the duration of endocrine therapy, you can increase the likelihood of patients remaining disease-free and also of patients surviving. So this was done with tamoxifen in the ATLAS study, and the ATOM study also showed that consistently when you increase the duration of endocrine therapy, you can increase the outcomes of patients. For tamoxifen, we are now at 10 years for most patients. For aromatase inhibitors, the 7-year mark seems to be the limit, at least for most patients, and we now have tools that we can use to identify patients who are at higher risk of late relapse and who may benefit from these approaches. But that's not the topic of the talk today. Another way of improving outcomes is to use better drugs, and that's why we now use aromatase inhibitors instead of tamoxifen for most, if not all, postmenopausal patients. You can see here that by using an aromatase inhibitor for 5 years instead of tamoxifen, you can reduce the likelihood of the patient recurring from her breast cancer, and you can also decrease her risk of dying. In premenopausal patients, in order to use aromatase inhibitors, you have to also use ovarian function suppression, and there were several trials looking at the difference between patients treated with tamoxifen plus ovarian function suppression, or an aromatase inhibitor plus ovarian function suppression. And these trials were analyzed jointly. It's the soft and the text trials. And for premenopausal patients with a high risk of recurrence, the current approach is to use an aromatase inhibitor plus ovarian function suppression, although when you look at overall survival, the differences are very small, and this approach probably benefits the very young, so patients below the age of 35. Using these new, not so new drugs now, increases toxicity. And this is really something that is very worrisome for a medical oncologist who sees patients in follow-up for 5 to 10 years, some even longer than that. You see here very interesting results on quality of life that were generated within the French CANTO cohort study. And you can see the evolution of patients' quality of life from the start of their treatment if they are treated with various treatment modalities. So patients who do not receive any endocrine therapy or chemotherapy don't have any significant reduction in quality of life over time. Patients who are only treated with chemotherapy, here in green, see their quality of life decrease, but it goes back up again after the end of their chemotherapy. On the other hand, patients who are treated either with endocrine therapy alone or endocrine therapy with chemotherapy have consistently lower quality of life over time. So what's important for quality of life is endocrine therapy and not so much chemotherapy, at least in the long run. And that's very surprising to a medical oncologist. Here are the guidelines that we currently use in Belgium to treat our patients. So you see that patients with low-risk disease are treated with tamoxifen if they are premenopausal and are treated with an aromatase inhibitor and ovarian function suppression if they are at high risk of relapse. And in the middle, we discuss. Now there are, of course, and that's the topic of my talk, ways to improve the efficacy of endocrine therapy beyond just using another drug. And these are all the different targets that we could use to increase the efficacy of endocrine therapy alone. We could use treatments targeting PI3K, mTOR, CDK4/6, and these will be the different parts of my, the next part of my presentation. We will also briefly discuss PARP inhibitors because I think they are very important in luminal disease as well. And then a few words on antibody-drug conjugates beyond what Professor Picard already told you in HER2-positive disease. So let's start with the CDK4/6 inhibitors, which in my opinion are the biggest revolution in the treatment of ER-positive, HER2-negative disease. So CDK4 and 6 interact with cyclin D, and they are important in the cell cycle regulation. So if you block CDK4 and 6, you will block the cell in a state between the G1 and the S phase. The cell will not be able to progress into mitosis. The first trial to show an improvement in overall survival using this approach, so a combination of a CDK4/6 inhibitor and endocrine therapy, was the MonarchE 2 study, whose results were presented recently at a major congress. And in this trial, patients with metastatic breast cancer, ER-positive, HER2-negative, no prior treatment, were randomized between endocrine therapy alone with a placebo or endocrine therapy with ribociclib, which is one of the 3 CDK4/6 inhibitors. And what we were shown very recently is that using this approach, we can actually increase median overall survival by 1 year. So hitting the 5-year mark, which is very, very important in this disease. All 3 drugs, palbociclib, ribociclib, and abemaciclib, have shown consistent benefit in progression-free survival, and the hazard ratios are the same for all these drugs in terms of PFS. Concerning OS, we only have 1 study that read out, so we don't know yet what the outcomes will be, but in later lines, there we see consistent benefit of all 3 CDK4/6 inhibitors. So I wouldn't want to promote one over the other. So these 3 CDK4/6 inhibitors, when added to endocrine therapy, will increase progression-free survival, and we now have data on OS for one of these. The side effects are not negligible because patients will take these drugs for up to 3.5 years in the metastatic setting, and they will probably experience side effects like neutropenia, which is usually non-febrile, so not so worrisome. There may be some drug interactions and also some diarrhea, especially for abemaciclib. Of course, when we've shown that the drug is effective in the metastatic setting, we always want to use this new tool in the early setting, and that's why several trials were conducted using these 3 drugs. The trial that showed the most beneficial effect was MonarchE, In this trial, patients with a very high risk of relapse, so again, ER positive, HER2 negative, very high risk of relapse, so for instance, more than 4 lymph nodes involved, were randomized to either receiving endocrine therapy alone or endocrine therapy plus abemaciclib for 2 years. We don't have any data on overall survival yet for these trials, but for the abema trial, we now know that it increases the likelihood of being disease-free after 3 years. You see here that it increases numerically the likelihood by more than 5%. So this drug has now been approved by EMA and by the FDA. There are other drugs that can be administered in combination with endocrine therapy. Let's briefly discuss PI3K inhibitors. So PI3K is part of this PI3K-AKT mTOR pathway that plays a role in malignant transformation, but also cancer progression and resistance to endocrine therapy. We know that 40% of patients with ER-positive, HER2-negative disease will have mutations in PIK3CA, and we can, of course, find this using next-generation sequencing, which is the usual approach, at least in this country. And we now have drugs that can target the PI3K alpha isoform of the protein. So PIK3CA is the gene and PI3K is the protein. Alpelisib is the most promising drugs. We now have results of a phase 3 trial that was presented by Fabrice André. And in this trial, patients who had progressed on prior endocrine therapy were randomized between either fulvestrant alone or fulvestrant plus alpelisib. And let's focus on the cohort of patients who had PIK3CA mutations. So these represent 40% of these patients. For these patients, Fabrice showed in his trial that using a PI3K inhibitor in combination with endocrine therapy increases progression-free survival with a hazard ratio of 0.65. Unfortunately, there was no statistically significant improvement in overall survival, and there are some toxic side effects of this drug, mainly hyperglycemia, diarrhea, rash, and stomatitis. Currently, we are not, although the drug has been approved by EMA, we are not allowed to use it in Belgium within the reimbursement system because of the lack of overall survival data and the side effect profile. The drug was not reimbursed by inamilisib. Now, let's move to an older drug, which also has a role in the PI3K-AKT mTOR pathway, mainly on mTOR itself. It's everolimus. It's, of course, always a little bit difficult to present trial data in front of the person who was one of the chairs of the trial. The Bolero-2 trial was conducted in quite similar patients to the SOLAR-1 population, so patients who had progressed on prior endocrine therapy, and these patients were randomized between receiving either exemestane, so endocrine therapy alone, or exemestane plus everolimus. And this trial also showed an improvement in progression-free survival, but no statistically significant improvement in overall survival, although there was a numeric advantage for using everolimus, and this drug is approved in Belgium, so we can still use it, and we can use it independently of the PIK3CA mutation status. Side effect profile quite similar to alpelisib. Classically, historically, when patients were treated with endocrine therapy in first lines and progressed, we had to resort to chemotherapy. But we now have other ways of treating these patients. I will discuss PARP inhibitors and maybe the future antibody-drug conjugates, at least for part of these patients. PARP, as you well know, is an enzyme that is involved in DNA repair and more precisely in base excision repair. Using PARP inhibitors is based on a theory of synthetic lethality. So when a tumor cell sees their DNA being damaged, the normal tumor cell, so a tumor cell that is efficiently repairing their DNA, can repair it using base excision repair, which depends on PARP, or homologous recombination, which depends on the BRCA status, so BRCA1 or BRCA2. And these cells then remain viable. In a patient with BRCA deficient cancer, so a patient who has constitutional alteration on BRCA1 or BRCA2, homologous recombination no longer works properly in tumor cells. And so these tumors are completely dependent on base excision repair to remain viable. By blocking base excision repair in these patients who have these specific tumor alterations, the cells no longer are able to repair their DNA and die. At least that's the theory, but it indeed works in patients. Usually BRCA1 or BRCA2 mutations are investigated in families with a large number of breast cancer patients, ovarian cancer patients, or in triple-negative disease. But the Olympiad study also included patients with estrogen receptor positive disease. All were HER2 negative. In this trial, patients were treated with a PARP inhibitor or, and this was randomized, or chemotherapy of physician's choice within a certain subset of chemotherapies that were allowed. And you can see that patients who were treated with the PARP inhibitor had better progression-free survival than the patients who were treated with chemotherapy. Unfortunately, the PFS of 7 months was quite disappointing to me, to be honest, but we now know that these tumor cells regain BRCA functionality over time when exposed to PARP inhibitors. This study was not a standalone study because there is another study called UMBRACA that used another PARP inhibitor, talazoparib, and it was actually designed exactly in the same way. You can make a copy-paste between Olympiad and UMBRACA, and the results are also quite similar because you also see an improvement, a modest, in my opinion, improvement in progression-free survival between patients who were treated with talazoparib and patients who were treated with chemotherapy. Final overall survival analysis did not show any significant benefit. And again, now that we have a drug that seems to be interesting in late-stage disease, we now also use it in early disease, here in combination with endocrine therapy in patients who are ER positive or in monotherapy in patients who are triple negative. So these are patients who were treated either with neoadjuvant chemotherapy and did not respond well to their chemotherapy, or who had, again, very bulky disease, patients with more than 4 lymph nodes involved. If they had ER positive HER2 negative disease, they were treated with adjuvant endocrine therapy, and they were randomized between receiving 1 year of olaparib, the PARP inhibitor, or a placebo. And you can see here, these are patients both triple negative and ER positive HER2 negative. You can see here that invasive disease-free survival at 3 years is improved in patients who took 1 year of olaparib. It's the same for distant disease-free survival, so a surrogate, I think, in my opinion at least, of overall survival, because as you know, most patients who develop distant disease, so metastasis, will eventually pass away because of their disease. So a new approach using PARP inhibitors. And then maybe the future, antibody-drug conjugates. Professor Picard already introduced trastuzumab deruxtecan. So very briefly, it's an antibody-drug conjugate that targets HER2 and that is linked to a very potent drug. The DAISY study was presented at San Antonio and was updated at ESMO Breast this week. Actually, these are the slides from San Antonio. In this trial, patients were treated with trastuzumab deruxtecan, whatever their HER2 status. But there were 3 cohorts. So there was cohort 1 with the true HER2 positive breast cancers, cohort 3 with the true HER2 negative, so 0 expression of HER2, and then cohort 2 in which patients had an expression of HER2 by immunohistochemistry, but no HER2 amplification. And if we just focus here on cohort 2 and the hormone receptor positive cancers, we can see that there were responses. You can see here on the waterfall plot, and in my opinion, interesting responses. And you can even see responses in patients who did not have any expression of HER2, at least measurable by immunohistochemistry. And this also translates into progression-free survival that is, of course, improved more dramatically in patients with HER2 positive disease, but in the hormone receptor positive subset of patients with low or no expression of HER2, you see interesting PFS results of 6.9 or 4.5 months. So these are also, there's also a new approach that could be used in our patients. So for HER2 negative, estrogen receptor positive disease, we now always go for endocrine therapy in combination with all these new drugs, then chemotherapy, the only exception being visceral crisis, so really very bulky metastatic disease that impairs the patient's prognosis within the next few weeks. That would be my definition. We rarely see these patients nowadays, but when there's no visceral crisis, then we go for endocrine therapy in combination with CDK4/6 inhibitors, followed by endocrine therapy with PI3K inhibitors if there is a PIK3CA mutation and you have access to the drug. Otherwise, you can always use everolimus, so the mTOR inhibitor. And then, of course, we have olaparib or talazoparib if there is a mutation on BRCA. Maybe somewhere here the antibody-drug conjugates. And then finally, what we all want to avoid as medical oncologists, chemotherapy. And I share your hope, and I hope it's not just hope, but also a vision that we will get rid of chemotherapy within our lifetime. So to conclude, Mr. President, we now use endocrine therapy for longer duration in the adjuvant setting. We use AIs in combination with OFS if premenopausal instead of tamoxifen. We add new drugs to the mix, and we have hope to get rid of chemotherapy for patients who progress afterwards. And on this note, I give the floor back to you.
Thank you very much. Extremely interesting. Looking forward for questions. From the audience, any question?
Thank you for your lecture. I have a question about breast cancer in men. Is it important difference in the treatment and in the characteristic of the tumors?
That's a very interesting topic you're bringing forward. Breast cancer is diagnosed in 1 out of 800 men approximately, so it's 1% of all breast cancer cases. There are around 120 each year in this country. So, and it's often neglected. So very often they will be diagnosed with later stage disease than women. Of course, we don't have randomized trials with all these new drugs that only focused on men, but thankfully many of these trials now also include men in their inclusion criteria. And so the approach would be indeed to use the same drugs than in women, with the caveat that ovarian function suppression has to be, well, OFS, it's not really ovarian function suppression, but LHRH agonists, let's put it this way, have to be used in these patients when we use endocrine therapy.
On a une question de YouTube du professeur, enfin du docteur, j'imagine Jean-Paul Salmon, pardon, qui nous demande sur quel rationnel limiter l'accès des anti-PARP aux mutations BRCA germinales et ne pas l'étendre aux mutations BRCA somatiques.
So the question of my good colleague Dr. Salmon is whether we should extend the use of PARP inhibitors to patients with somatic BRCA mutations, and so go beyond the germinal mutations. Contrary to ovarian cancer, in breast cancer, somatic BRCA mutations in the absence of constitutional mutations are quite rare, but they exist. We don't have data, unfortunately, for these patients concerning the use of PARP inhibitors because of the inclusion criteria of the studies, but I completely share your enthusiasm on also using these drugs in this very rare subpopulation, indeed.
Merci, professeur.